Hello again. Now, one of the things that we've done on EASD TV this year is talk about futures. And here comes another of those futures sessions. And I'm delighted to welcome Manuela Battaglia from Inodia.
Yeah.
And you can tell us what Inodia is in a minute. And Florian Toti from the University of Medicine in Tirana, Albania. And we're going to talk about futures in terms of treatments with you both. And you're going to do type 2 and you're going to do type 1. Okay, very good. So let's kick off with you. Tell us what Inodia is.
Yeah, so Inodia started 7 years ago as a European funded project. So the European community invested a lot of money together with partners from pharma in a project to build an infrastructure in Europe made of scientists and clinicians working in academic environment to support pharma to develop disease-modifying therapies for type 1 diabetes. Pharma or investigators, any drug developers, they achieved a lot of successes. It was a very good project, but as any funded project has an end, unfortunately. So the funders decided to made not a company organization, a non-profit organization out of this project. So to leverage all the results that were achieved in the European funded. So they founded an international non-profit organization that is still called Inodia. That's a bit of a confusion, but it's a different entity that leverages on those results. So the goal of Inodia is to facilitate and accelerate the development of disease-modifying therapies in type 1 diabetes.
So you are very, very well placed then to tell us where you think the future of treatments is going. I mean, we've seen spectacular success in the last 2 or 3 years.
Yeah, so I think definitely we need to be more courageous and try new therapies now. The field is ready. The academic world is ready to run new trials with new disease-modifying therapies. Definitely, islet replacement is something big that is coming, but also biologics, antibodies, and that can modify the disease and really cure it.
That I think seems to be really taking off, the modification of disease.
Of the disease. The thing is, we have to put a big focus on personalized medicine. I think the field of type 1 now is ready to understand and recognize different phenotypes of disease, or endotypes, how they call, and so different origin of the disease. So different people will respond differently to different therapies. So something that happened in the oncology fields already, that they design therapy based on characteristics of the patients. I think we should do this now in type 1 diabetes as well.
And the other thing that I think we're beginning to see is the kind of combination approach. I mean, again, very much like oncology.
Absolutely.
Where you're seeing not just
one. We need probably to hit
medicine,
different
but
targets.
all of them, kind of personalised to your particular to particular issues. Now, what about in type 2? I mean, again, massive success in terms of weight reduction.
Yeah.
Where else are we going?
Well, as we have already seen, the main problem with diabetes is related with obesity. So that's why we call today diabesity. So it's not two separate diseases, but it's the same disease in the same person, because most of the type 2 diabetic patients are also obese or overweight. So this is the main focus actually, to reduce the weight for these patients, because with that we have seen that we are not only improving metabolic control, but we are also reducing the cardiovascular risk and improving the quality of life for people with diabetes. So this is the main focus, but it's not only that's for sure. And what is more important, it's still important, the motivation of the patient and the communication between healthcare providers and the patient. But as you have already mentioned, there are a lot of medicine or studies suggesting that using some drugs, like it is GLP-1 agonist or tirzepatide now, that is a combination of GLP-1 agonist and GIP, we have seen a massive reduction in weight, and also kind of remission of type 2 diabetes for a short period of time. We hope that it will be for a long period of time, but for the moment we have just seen some results that are very encouraging for the future.
Now, can I ask you both, one of the things that we're seeing is this huge demand. I mean, absolutely enormous demand. And is that a temporary blip? Is it going to, do you think we're going to get a lot more drugs coming on stream? And can the companies that have bought those products in sustain the competition that's going to surely come from, say, India and China? What are your thoughts on that?
Well, I think this is something we will have to handle. So a lot of therapies are coming, and so there will be a lot of competition. But again, I think each company has to find its own niche in terms of patients that will really benefit from their treatment. So we still need a lot of research on type 1 diabetes to really have the right therapy for the right people. So then I think there will be space for everybody, because we will need a lot of different therapies.
I mean, presumably, Florian, what we're going to get as well is, obviously most of these amazing drugs are injectables, and presumably there'll be a drive towards small molecules so that we'll get oral preparations.
I was just wondering what you said, because when we propose the insulin to people with diabetes, to start insulin, they don't accept it. But when we propose a GLP-1 agonist, it's again an injection, they accept it. So it's not the problem only of the injection, it's the idea behind, because the insulin has been the last resort that we have against diabetes. So it was a kind of failure for both healthcare provider and people with diabetes. While for the GLP-1, it's not the same thing. So the people accept more easily, even the overweight people now. That's why it's a huge demand for these kind of medicaments. And we are lacking this treatment for the people with diabetes that can improve more, and they can have more results and efficacy due to this treatment. And there are a lot of people that are lacking this kind of treatment because it's using out of label. And I see that, and I hope that it's not just a problem of a short time, because we have seen people losing weight with this treatment. But once they stop the treatment,
it all piles back on again.
Even more. So I think we need to still focus and talk with these people that it's important to continue with the diet and physical activity to maintain the weight that they have lost. So this is very important. And I think we need to choose, as Manuela has said, a personalized treatment for people with diabetes. It's not a treatment for everyone.
Although it seems, I was going to argue with you a bit there, because yes, people pile back on the weight, but not all of the weight. And maybe one of the things that we'll have in the future is different dosing regimes, where people go on, they cycle on and cycle off these drugs. So they're not on them all the time, because one of the things we know is that people are very bad at taking drugs all of the time.
Yeah. It's important. It's important to know these things, and that's why I'm saying that it's important to choose the right dosage, the right time, and for how long to take a treatment. Again, before to decide or to stop or to reduce the dose for the treatment, because we know a lot about the positive effects of these medicaments, but on the other hand, we still don't have too much experience with the long-term effects or even the secondary effects of these drugs.
Okay, I'm now going to push you to get your crystal ball out and I'm going to ask you, first for type 1 then for type 2, what we're going to see by the end of this decade, and then what we're going to see, say, into 2035. So let's start with you.
Well,
by the end of this decade, what are we going to see for type 1?
That's really a very difficult question.
This is a crystal ball.
Yes,
exactly.
this is the crystal ball.
Let me look at my crystal ball. I don't have it, so I can tell you the way I see the medicine development should develop. meaning we should include patients much more in the decisions-making processes. We should have academic sites that are ready to interact with the pharma, and we need to have pharma that listen to the academic sites to develop their drugs better and faster. So that's the way I will see in 10 years as a way of acting rather than, a real product. And I think if we implement this, then everything will be smoother and many more drugs will be available for patients.
Okay, she slightly dodged the question.
Well, probably because for type 1 diabetes, it's a little bit harder to know what will come on the future. Even for the type 2, we still don't know anything, but at least we have some general points that we can say that are very promising. So first of all, we have oral insulin already. So we are almost trying to take off the injections of insulin. On the other hand, even for the GLP-1, we have already oral treatment. So the injections are becoming less and less important, but still they are important. For the insulin, we have now insulin that we can do any 2 or 3 days. So there are good results and good hopes that in the future we will have a better adherence for the patient, but still it is important to continue the communication and the follow-up of the patient and to choose which is the best treatment for each of our patients. And one last thing, the prices of the drugs. It's very important to have affordable prices, not for everyone, but at least for as much people with diabetes as possible.
So access remains a major problem.
Absolutely.
Okay, terrific. Thank you so much, both of you. And I think there's another future session that we've got, but stick with EASD TV. Bye for now.